Okay. Now I invite Dr. Anju Chandran for the next talk. She is currently the oculoplastic consultant and academic in charge in Compress Eye Hospital, Calicut. I welcome Dr. Anju. She'll be talking on botulinum toxin.
Yeah. Thank you, Shebin, for this invite. It's always a pleasure to be a part of a group like this, and thank you, KSOS. So, Saumi has made my job much simpler because she has given a detailed graphic representation of all the disorders. So, I have no financial disclosures whatsoever in the presentation. Okay, so what do these two gentlemen have in common? Can anybody volunteer? Obviously, they belong to two different eras, which is very clear. And the person on the left is Justinus Kerner, and he is the reason why the person on the right, whom we all know as Badshah, is still looking young. So, Dr. Justinus Kerner is the one who diagnosed and described botulinum toxin or botulism for the first time in the 19th century. So talking about the toxin, it is derived from a gram-positive anaerobe rod, which is Clostridium botulinum, which is usually present in plants. And its first therapeutic use in ophthalmology was described in 1981 by Alan Scott in strabismus. It has gained FDA approval for use in ophthalmology. If you were to look at the mechanism of action, it integrates with, it acts at the presynaptic neuromuscular junction where it integrates with the presynaptic vesicles and prevents the release of acetylcholine, which prevents the transmission of, which prevents the neuromuscular transmission, thereby causing a neuroparalysis in that region. So the onset of action is basically beginning from 3 days and it peaks at 3 to 4 weeks. And the duration of action is usually for 4 to 6 months, which means you need to give repeated injections. Different subtypes have been described, of which the most potent one is botulinum toxin A, and the other usable varieties are botulinum toxin B as well, and two commercially available types are botulinum toxin A, which are available in different brand names. The therapeutic indications in oculoplasty is what we will be dealing with today. So as Saumya already spoke in detail about the various facial dystonias, I will not be going into the details of the same. The other indications would be in upper lid retraction, such as in thyroid eye disease, and in exposure keratopathy, lower lid spastic entropion, and aberrant seventh nerve regeneration, where the patient usually complains of epiphora, in which case botulinum toxin will be very useful. Similarly, lacrimal hypersecretion due to various causes such as punctal stenosis, canalicular block, etc. And of course, cosmetic purposes. So the contraindications are, it should differ from use in patients with peripheral motor neuropathic diseases such as myasthenia gravis, as the effects can be debilitating, leading to even death. And it should be used in caution in patients with amino acid antibiotics or other agents. And you should look for any inflammatory or infective conditions in the area of injection. And since the effects are unknown in pregnancy and lactation, better to stay away from administering the same. Like I mentioned earlier, several preparations are available. And it's available in different varying concentrations, starting from 50 units to 100 to 200. And the one that I like using is Botox, which is available either in 50 or 100 units. And it comes as a freeze-dried formulated preparation, which needs to be reconstituted before use. And it is good to note that there is a cold chain that has to be maintained right from acquiring the drug to preparation and use till administration. So this is a brief video showing how you need to, how you can prepare, for which you need 0.9% preservative-free normal saline. Depending upon the concentration that you are comfortable with, you can dilute it. I like using 2.5 international units per 0.1 ml. Like I mentioned, the cold chain needs to be maintained throughout. So while you are preparing, as well as while you are mixing the the saline into the drug, you need to make sure that you do not give vigorous movements, because this can destabilize the drug and lower the efficacy. So an informed consent needs to be taken prior to the procedure regarding the complications and the effects that the patient should expect, and also that the need for repeated injections need to be explained to the patient. Preoperative instructions such as stopping anticoagulants mainly because to prevent any ecchymosis or post-procedure bleeds, use of green tea and anti-inflammatory medications. One should note that a cumulative dose not more than 100 units should be given over 12-week period. So I will not be going into this because Sami has already covered that. So this is a patient with hemifacial spasm. As you can see, here we are administering with the use of a 30 gauge needle. Prior to the procedure, the patient was prepped with numbing cream. In this case, we have used a prilocaine cream, which is applied and kept for at least 20 minutes before the patient is given the injection. And in the periocular region, since there is no subcutaneous tissue, we give a subcutaneous injection. As you can see that there is a small blood formation along the lids, and the other muscles, which are the deeper muscles, we pinch so that it is introduced into the muscle as such. So I still prefer marking the sites for injection. One, because it helps, it eases with the administration, and second thing, it also gives me a track of how much unit I am inserting at the same. So in a patient with hemifacial spasm, usually we give 35 to 50 international units per sitting. So this is a patient with benign essential blepharospasm. This lady was in distress because she had to depend upon her children for her daily activities. She in fact came in a wheelchair and said that it has been months since she was able to do anything on her own. And this was her following a post-botulinum toxin injection. In her case, we gave mainly in the orbicularis oculi muscle and also the procerus and the corrugator muscle. And cumulative of usually 50 units is given. And now she is very happy and she is waiting to get out of her wheelchair and start losing all the weight that she gained over these days. So this was a patient with corneal ulcer. So in his case, what we have achieved with an injection botulinum toxin is to induce a complete ptosis, which gives time for the ulcer to heal over the period. So in this case, we have given a transconjunctival injection into the LPS muscle. Depending upon the effect that you need, around 5 to up to 10 units can also be given for the patient. So this is lacrimal gland injection that we are given. In this particular patient, she had a canalicular block, common canalicular block, and she was distressed by the epiphora that she had. So care needs to be taken that you should be able to visualize the lacrimal gland well before you inject. Again, prior to the procedure and post-procedure, you need to keep a track of the tear production, which you can do by various tests. And you should also warn the patient that post the procedure, initial period, there will be severe dryness for which lubricants need to be given. So here around 2.5 to 5 units can be given per lacrimal gland. This was a patient with an upper lid retraction and thyroid eye disease. He was already receiving treatment for active thyroid eye disease, and here in his case we have given injection into the LPS muscle to induce ptosis, lower the retraction in both eyes. And in this particular case, as you saw, we have given a transconjunctival. You can also give a transcutaneous one into the LPS muscle right away. So in entropion, the definitive treatment, as we know, is surgical management, but you can use botulinum toxin to basically buy time for the patient, or prior to cataract surgeries where the patient is waiting for has been advised to undergo, like in mature cataracts or hard cataracts. Again, it is short-lived, so the patient has to undergo a definitive surgery. Cosmetic indications are various, such as for the forehead lines, for the bunny lines on the nose, for crow's feet. What you can also achieve is, in this particular patient, if you can see bilaterally, there's a slight hooding and the patient is bothered by the dermatochalasis. So we have achieved what is called a chemical brow lift by negating the depressors and injecting a bit into the tail of the eyebrow. Similarly, the forehead lines were also gotten rid of by injecting botulinum toxin of 2.5 units at multiple sites at the presence of the mounds or the furrows that you can see, because those are where the muscle bellies are. And this is the resultant effect. So postoperative care is, especially in lacrimal gland botulinum toxin, you should ask the patient to avoid lying down for at least 4 hours, because you do not want the medicine to track elsewhere and cause ptosis for the patient. And also in patients who have undergone injections in the periocular region or in the face, it's better to avoid face massage at least for a week. Complications, we can divide them as injection related and neurotoxin related. Injection related, as in any injection, would be pain, infection and ecchymosis. And neurotoxin related, most common would be ptosis, but you can assure the patient that it is transient and then it will slowly get back. And diplopia, if it has tracked into the extraocular muscles. Lag of thalamus, as you can see in that patient who received for upper lid retraction. Midfacial weakness and dry eye, for which you invariably put all your patients on lubricants, even in patients with hemifacial spasm and benign essential blepharospasm. So with that, I end my presentation. Thank you, Shebin. Thank you all.
Thank you, Anju. It was very well presented and all beautiful results.